Hi, nice to meet you all. Thank you so much for the invite. It's a pleasure to be here. So thank you to, come this side. Thank you to Nuno and team, a little bit further. I think it's my height as well. So first of all, I'd like to also thank you to Zena for a really great talk. And I'm a big believer in translating research into practice. I'm a lecturer at UCL, associate professor in nutrition, but my original background was studying muscle, so skeletal muscle at a molecular level. So I was interested in muscle wasting conditions. This is going back 20 odd years ago. But I started to realise when I was teaching this stuff to students, what's most important actually on the ground, for example in hospitals and care homes, is how do we actually assess for key things that are important that might affect, for example, physical function. So it's nice that sarcopenia has already been mentioned, which is loss of strength and function with ageing. It concerned me, this is one of my big sort of missions in life, is that, for example, if you go to hospitals, when you get screened for malnutrition, you use something called the MUST tool that you might have heard of before. So it's a very simple tool that is used for all adults. It just looks at body mass index and weight loss, but doesn't tell you very much information. It's a very inaccurate tool, okay? And it means that people can be missed. And the work that I did back at Lincoln Hospital some years ago, where we looked at frail older hospital patients, they might be comorbid, they might have forms of disability or immobility, so they might tick the boxes with having comorbidity, lots of conditions and problems on polypharmacy, but the MUST tool would say they're perfectly fine, have a normal nutritional status, they're not malnourished, and that doesn't make any sense, okay? So I've made it my sort of interest and passion to try to promote some really good quality malnutrition assessment and sarcopenia assessment, which is what we should be doing. So looking at the current global consensus statements, the experts around the world have suggested we should be doing certain things differently. Why is this important? The reason it's important, again, going back to as an example in hospitals, if a patient is diagnosed as being completely normal in terms of their nutritional status, they will never see a dietitian. They will never get nutritional support, okay? And usually what happens is not until it gets too late where someone loses a huge amount of weight that someone gets seen or actually properly looked at. So thanks to Nightingale Hammerson, Nuno and Carolyn team, we're doing a really great study this summer with some really excellent students, so hopefully they're online. So Emma Harris and Anissa Ratmayanti actually looking at trying to improve assessment of these things like sarcopenia and frailty that all linked together, okay, which affect quality of life. It affects mobility and mortality, disability risk, all these different things, as well as obviously care costs. So what we did was first of all try to assess people using current practical screening tools, things like questionnaires, to measure this thing called sarcopenia, which is where we have, for example, loss of physical function, things like frailty, which is closely intertwined, and there's different definitions of frailty, which some of you might be aware of. And so we were interested in this because typically in most care homes, a lot of these things aren't done routinely, actually. And we're very lucky the fact that we have the opportunity to research this. And you might see, for example, here, if I just try to, is there a pointer there? But I'll just point anyway. So this is the sarcopenia screening questionnaire. This is called the Frail scale. It screens for physical frailty. And so these are malnutrition screening tools. And there's high variability between different tools that we use, okay? And so we found we've got extremely good care in the care homes here, which is great to see. However, we have to see that the fact that a lot of these residents are very old, they might have comorbidity on polypharmacy and have disability. So it's expected to be a high amount of low physical function and sarcopenia. So it's important to highlight these things because they're sensitive markers. And if you have that sensitivity, it could mean you can predict certain things and predict them in advance. And in terms of malnutrition screening, this is the MUST tool that I was talking about earlier. So it shows that 77% of people have good nutrition. Now, we showed there's a very good nutritional care in these care homes. However, it doesn't make much sense because just the effects of aging alone and comorbidity, you expect that it's going to have a negative impact on physical and nutritional status. So if you've got a more sensitive measure, like for example, this is the MNA, so if you go to France and Europe, for example, just by going over the water, you get a different screening tool. So again, let's go the same example going back to hospital. If you're in France, you would see a dietitian. 50% of these people would see a dietitian. So this is important because you need sensitive measures and markers. We also use, so these tools here, these are very simple, practical screening tools that you can use. So anyone could use these. We also use some cutting edge techniques. This is bioelectrical impedance. So you have a little portable device where you put a very small current through the body. It only costs around £5,000. It's compared to a DEXA scanner or a CT scanner, it's a lot cheaper and it's portable. But it means we can actually assess, because when we just look at body weight, it doesn't tell us anything. But what are we made up of? So we're made up of things like our muscle mass and our protein. We can measure that. So again, we have more sensitive measures for looking at body composition, nutritional status. And we found, for example, that a lot of the residents actually had this low fat free mass index, so everything that isn't fat mass. Again, this is to be expected. If you have a resident that's 85 with comorbidity, it's to be expected, but at least we have a sensitive measure. So if we do something like some activity, some exercise or nutritional intervention, we might be able to see change, and that can predict outcomes. And to finish off, we also did an education and focus group sessions. The students did these, they did a really great job. And it's about trying, because this is the whole thing, it's trying to improve awareness. So are we using, do we even know about these terms? So lots of carers are not even aware of the term sarcopenia. If you ask nurses in hospitals, most people aren't actually aware of what these things actually mean and how they affect people, okay? So trying to promote awareness is very important in the first place. And understanding that all these things are interlinked. Because when we think of malnutrition, we think it's just that we're not consuming enough food. It's far more complex than that. So we need education, and that's what we're trying to do. We need to promote use of more accurate, practical screening tools, and then think about different things that can be suggested for trying to improve status and help to improve quality of life. And I think I'm probably at time now. And so thank you very much. Cheers. Thanks.